Bacteriology. Majority of the cases of calculus cholecystitis are due to organisms such as E. coli, streptococci, salmonella, and Klebsiella, etc. Typhoid fever can also cause typhoid cholecystitis after a couple of weeks of infection. Clostridial infection of the gallbladder produces acute cholecystitis with toxemia. Clostridial diseases are caused by anaerobic bacteria that are widespread in the environment, particularly in soil, and are often fatal. Toxemia is defined as blood poisoning by toxins from a local bacterial infection. Further classification. Cholecystitis is also categorized as calculus, acalculus, and emphysematous. Calculus cholecystitis is the most common type of acute cholecystitis. It accounts for around 95% of all cases. It develops when the cystic duct gets blocked by a gallstone or thickened bile salts, known as biliary sludge. Acalculous cholecystitis, which is less common but far more sinister, is the inflammation of the gallbladder without evidence of gallstones or cystic duct obstruction. Emphysematous cholecystitis, known less commonly as Clostridial cholecystitis, is an acute infection of the gallbladder wall caused by gas-forming organisms, for example, Clostridium or Escherichia coli, that is considered a surgical emergency. Risk factors and etiology. Calculus cholecystitis is more common in the Caucasian population, obese individuals with BMI greater than 30, females, flatulent, people who suffer from noticeable accumulation of gas in the alimentary canal, fertile females with one or more children, if the age is greater than or equal to 40, in patients with a family history of cholecystitis, in patients who are on fast weight reduction plans, pregnancy and hormonal pills. Acalculous cholecystitis is possible in case of critical illnesses, trauma, major surgeries, severe burns, sepsis, carcinoma of the gallbladder, severe malnutrition, HIV and AIDS. Signs and symptoms: abdominal bloating, flatulence, decreased appetite, nausea, vomiting, sweating, pain in the right hypochondrium or epigastrium radiating to the right shoulder or scapula, fever, tachycardia, jaundice, positive Murphy's sign. Diagnosis. Following investigations are routinely performed to make a diagnosis: ultrasound abdomen, total white blood cell count, blood and urine sugar. Abdomen X-ray in erect position can be helpful. CT scan abdomen if ultrasound is not helpful. Ultrasound abdomen is the investigation of choice. It can not only confirm the diagnosis, but also reveals valuable information about the extent of the condition. Ultrasound shows pericholecystic fluid, distended gallbladder, edematous gallbladder wall and gallstones. Murphy's sign can be demonstrated on ultrasound examination. Sonographic Murphy sign is defined as maximal abdominal tenderness from pressure of the ultrasound probe over the visualized gallbladder. It is a sign of local inflammation around the gallbladder, along with right upper quadrant pain, tenderness, and/or a mass. It's one of the most important sonographic signs of cholecystitis. Color Doppler ultrasound shows hyperemic, pericholecystic blood flow and acute inflammation. It can demonstrate stones, which are not always visible on X-ray. It is effective in more than 95% of cases. It can demonstrate inflamed, thickened gallbladder even in the absence of gallstones, which is known as acalculous cholecystitis. It can reveal gallbladder polyps, not possible to detect on X-rays. So how the diagnosis of cholecystitis is made on ultrasound? Gallbladder wall is greater than 3 mm in thickness. Wall striation. Pericholecystic fluid. Intramural gas. Mucosal sloughing. Echogenic bile or sludge. Transverse diameter greater than 5 cm. Total white blood cell count is raised in such patients. Blood and urine sugar is tested to rule out diabetes. Pain X-ray abdomen in erect position can be helpful to reveal or rule out other causes of acute abdomen, such as perforated gut. Pain abdominal radiographs can also show radioopaque gallstones in about 10% of cases, and gas within the gallbladder wall in case of emphysematous cholecystitis. CT scan abdomen is another useful diagnostic modality which is frequently used to make a diagnosis. Differential diagnoses: appendicitis, perforated peptic ulcer, acute pancreatitis, acute pyelonephritis, right lower lobe pneumonia, subphrenic abscess. Treatment: there are two approaches for treatment, surgical and non-surgical. Conservative medical management for majority of cases, which include antibiotic therapy. Broad-spectrum antibiotics are given against gram-positive, gram-negative, and anaerobic organisms. Antispasmodics. Analgesics, along with antispasmodics, are frequently used to help alleviate symptoms. Approximately 10% of cases of acute cholecystitis require urgent cholecystectomy. In such cases, high-grade fever, sepsis, shock, and high leukocyte count are among the deciding factors. Acalculous cholecystitis and perforated gallbladder with peritonitis certainly require cholecystectomy urgently. Prophylactic cholecystectomy, which is surgical removal of gallbladder with stones, but without symptoms, is often performed in diabetics, in patients with congenital hemolytic anemia, and in patients undergoing bariatric surgery. Chronic cholecystitis. Recurrent episodes of cholecystitis convert the gallbladder into a contracted, fibrous, non-functioning shrunken gallbladder. Gallbladder wall is grossly thickened. Stones are almost always present. Such patients present with classical fatty food intolerance. Murphy's sign is positive. They are diagnosed by ultrasound, which reveals a small contracted gallbladder with thickened walls. Preventative measures: healthy and balanced diet, exercise, lifestyle modifications. If you're trying to lose weight, avoid crash diets and opt for gradual weight loss plans. Recently, ketogenic diet is suggested by some, as healthy butter and fats are used in this approach, which decreases the risk of acute cholecystitis.